Good evening, and welcome to the first installment in a series of 6 virtual town halls being presented by the Neuro Valley Public Health Task Force. We appreciate you welcoming us into your homes or wherever you may be viewing this event. You will learn as we move through our program, the Neuro Valley is blessed with leaders who care deeply about our communities, and they truly work well together. As a result, our citizens should feel confident as we collectively navigate COVID-19 in the Neuro Valley. My name is Kevin Bird, and I'm the Executive Director of the Neuro Valley Regional Commission, and I have the pleasure of serving as moderator for the virtual town hall series. The Neuro Valley Public Health Task Force, I referenced earlier, has been hard at work since early March, aligning resources and deploying strategies to support the public health needs of our region. Nearly 3 months ago, local law enforcement, fire and rescue organizations, hospital and public health officials, county, city, and town managers, local public information officers, education officials, and others, with an unprecedented level of collaboration, began to develop and activate regional plans for the COVID-19 pandemic. Since then, the Neuro Valley Public Health Task Force has been working through Phase 1 mitigation, providing increasing levels of testing to all communities in the region, and securing testing resources and protective equipment for frontline medical and public safety personnel. Each week since March, the task force has provided flexible, adaptable, scalable drive-through test sites across the Neuro Valley with faster turnaround for test results. The task force also prioritized clear and consistent messaging and an abundance of public information, a result of which is this 6-week series of virtual interactive town halls, which begins tonight. Our series begins with the topic of healthcare. The panelists assembled this evening are directly involved with decisions being made to assist the Neuro Valley through COVID-19. The questions they will be addressing were submitted by residents across the region prior to tonight's town hall. For information about the series and to submit questions for future panels, please visit www.montva.com/NRV Town Hall. You may also submit live questions via Twitter by using the hashtag NRV Stronger Together, and we will answer them as we're able with time permitting. As I introduce each panelist, they will briefly overview their role with COVID-19. First up, we have Bill Flattery. He is the President and Chief Executive Officer of Carilion Neuro Valley Medical Center. He also serves as Vice President of Carilion Clinic, Western Region. Bill?
Thank you, Kevin. I want to start by thanking our local health department led by Dr. Noel Bissell. Our health department is extraordinary and is a shining example for other health departments across the country. We're lucky to have you, Noel, and I appreciate your leadership and your caring and compassion. I also want to thank and acknowledge Anthony Wilson, our Blacksburg Chief of Police, for his foresight and leadership in establishing the Neuro Valley Public Health Task Force in February. The coordination and cooperation I've seen through the task force epitomizes what is good about living and working in the Neuro Valley. You know, these are strange times for all of us. The virus has disrupted our lives in ways that we could not have imagined just a few months ago. Hospitals have always been the refuge for a suffering community, but we had to ask our patients to stay away out of concern for their safety. We stopped doing non-emergent surgeries and radiology studies. We pivoted our outpatient practices to focus on telemedicine, accomplishing nearly 80,000 virtual visits in 2 months' time. People stayed away from our emergency departments. Our volumes are down between 40 and 70%, depending on the services that are offered. I worry that people have put off needed care. We are now reopening services with the governor's permission. We are doing it in a safe and thoughtful manner, and I look forward to welcoming people back to our hospital campuses as we continue our healing mission. Thank you for allowing me to be a participant on this panel.
Thank you, Bill. Our next panelist is Dr. Charles Bissell. He is a section chief for Western Region Surgery at Carilion Clinic. think we got you on mute still. I think you're still on mute there, Dr. Bissell.
My lips are moving. All right, Kevin, sorry, thank you. My role on the panel is to be the liaison for the task force in Carilion. So, I go back and forth and then help represent that way.
Great, thank you. Next, we have Dr. Dave Roberts. He is the Chief Medical Officer with the Community Health Center of the New River Valley.
Thanks, Kevin. Like everybody else, I'd like to extend my thanks for being included in the panel. The Community Health Center has got 3 clinics where we provide primary care, behavioral health, and dental care. And my role really is managing the medical part of our response to this COVID pandemic.
Great. Thank you, Dr. Roberts. Next, we have Alan Fabian. He is the Chief Executive Officer of Lewis Gale Hospital, Montgomery.
Thank you, Kevin. I would also like to echo the thanks to the New River Valley Task Force, Dr. Bissell and Anthony Wilson, Chief Wilson, and doing all the great leadership that they provided for our community. It makes a difference when these type of leaders step up and certainly protect the resources we have to protect our community and our constituents. So I work for Lewis Gale Regional Health System. It's a 4-hospital system in this area, and our focus has been not just to prepare for a pandemic and take care of patients who may have COVID virus, but also to create a space where we can protect and take care of patients who don't have the virus. And so that's been a large focus, is to prepare the community to continue to give people who have chronic diseases a place to go get their health care.
Thank you, Alan. Next, we have Dr. Billy Cox. He is a hospitalist medical director for Lewis Gale Hospital, Montgomery.
Hi, thank you. My name is Billy Cox, and I'm the hospitalist medical director at Lewis Gale Montgomery Hospital. I've been here almost 13 years serving this community, which I'm very, very proud of. Also, I'm the internal medicine residency program director. I've been a member of the NRV task force, and I really appreciate the support of not only everyone on this panel, but for other leaders in the community. My primary specialty is hospital medicine. And so myself and my colleagues, as well as nursing staff and others in the hospital, have been on the front lines helping treating patients with COVID-19. So I appreciate you having me on this panel.
Thank you, Dr. Cox. Next, we have James Pritchett. He is a licensed clinical social worker and executive director of New River Valley Community Services.
Thanks, Kevin. I appreciate the introduction. As you said, I work for New River Valley Community Services, and we're the public provider of behavioral health care services for the New River Valley. We have several independent clinics throughout the New River Valley, and our primary responsibility is to make sure services, people have access to behavioral health care services, whether that's a mental health issue, a developmental disability, or a substance use disorder. And we all know during times of a crisis, those kind of issues don't take a back seat. And sometimes they even become more prevalent during a crisis. So we're here to make sure those needs are taken care of. And we're glad to be a part of this team and work together to try to address our community's concerns.
Great. Thank you, James. And last but certainly not least is Dr. Noelle Bissell. She is a director of the New River Health District with Virginia Department of Health.
Thanks, Kevin. So my role is as the director of the health district to be VDH's representative here in our region. We are available as a resource for our community members, our community partners, to help provide guidance during this time as new guidance becomes available, which is pretty much a daily changing thing. We have coordinated the testing effort in the New River Valley, and then we also get all of the positive results. So we coordinate the contact tracing and the follow-up and recommendations for ongoing testing, quarantine, and isolation in the New River Valley as well.
Great. Thank you, Dr. Bissell. Well, thanks to each of our panelists for joining us this evening. They're going to be providing insight on the response to COVID-19 in the Neuro Valley. We're going to start off with a general overview of COVID-19 from Dr. Bissell at the Health District to help frame our discussion this evening.
So COVID-19 is a virus. It's a respiratory virus. It's a novel virus, meaning we haven't seen it in our communities before. It's never been seen. It usually is spread by droplets that can be spread by coughing or sneezing, or much less so by contaminated surfaces. We have seen that it has spread very quickly, and the reason it has spread very quickly and very widely is that it is a novel virus, so we don't have any immunity to it. There is no herd immunity from prior exposure, and there is no vaccine available to provide that immunity. So that's the biggest issue with it. It's unlike any infection that we've seen before during this time. I'll go on to just talk about how we detect the virus. We know that the main symptoms of the virus are respiratory. It causes shortness of breath, coughing, difficulty with secretions, breathing, sore throat, and it can cause a pretty bad pneumonia, which is what gets people into real trouble where they end up in the hospital, and that's where we see the most severe cases. It does affect other organ systems. It can affect the heart. People have been presenting with heart attacks and things. It causes the blood to clot a little bit more, and so it can be seen in people who have strokes and some other conditions. It also has a lot of other manifestations that we're just learning about. Every day, every week, we learn more about how this virus presents. It was first identified in the end of December when it was first noted by Wuhan, China. Within a week, we had already done the genomic typing on it. So we knew the genomic sequence on the virus. And at that point is when we started looking for ways to identify it. Right now, there are two ways that we look at trying to identify people who have been exposed to COVID-19. The most common one right now is the nasopharyngeal swab, which is a molecular test that actually looks for the virus itself. And that tells if someone is infectious. The other one is an antibody test. Those are very new. They're not quite honed, and we don't really know their utility at this point because we're finding that this virus does not behave like a lot of typical infections do. But the antibody is not the virus. That's the protein that your body produces in response to an infection. And usually when we follow the antibody, we look for a level of immunity that develops as a result of an infection. So when we're in the midst of it right now, we really want to know that molecular test result because that's going to tell us if there is virus present and somebody is actively infectious.
Okay. Well, thank you. Based on the volume of questions we've received prior to the town hall this evening, it's apparent that testing is really in the forefront of many people's minds. So Dr. Bissell at the Health District, can you start off by overviewing the testing in the region and the types of tests that are available?
So we, at the Health District, the main test that we are doing is the PCR because that's the molecular test for the virus itself. And as we're looking at the disease prevalence in our community, we want to know how many people are actually carrying the virus and potentially infecting others with the virus. So that's the nasopharyngeal swab. As everybody knows, testing initially was very challenging. There were some difficulties with the first tests that were developed, and then they were slow to be produced. We are catching up. We're still not to the point where everybody can get tested or everybody needs to be tested. So we had some screening criteria that we had to use initially. And it still goes up and down based on availability. It also based on lab capacity. We have to have a lab to send the test to. So we have to have the supplies to conduct the test. And based on the availability, we're able to offer our testing sites and we're able to offer testing to as many people as we can. The antibody test, again, that's something that we're learning a lot about. It's not a typical antibody response. We've partnered with Virginia Harm Reduction Coalition to offer it at our sites. And people tend to want to prefer that because it's just a finger stick versus the swab in the back of the nose. But because it's not as reliable, we really can't just offer that solely. So we're offering it in conjunction with the molecular test, the nasopharyngeal swab. And then we also look at somebody's clinical history, when they've been sick, how sick they were, what symptoms, how long ago, if they're still sick. And we try to paint a picture of the evolution from the potential exposure, the time of infection, how long they were infectious and symptomatic, and then on to recovery and whether or not they've developed the antibodies.
Is testing currently available for those who do not have symptoms and are unaware of any contact with people who have tested positive for COVID-19?
So right now in the New River Health District, we've been very fortunate. Our localities have offered tremendous support financially, as well as resources, that yes, we are able to offer very broad testing. I can't offer testing to every single individual, but we at this point have opened up our testing to the people who are symptomatic, people who are contacts of known COVID cases, and people who just want to know. Today, we were out at Giles High School testing, and we tested 137 individuals, many of whom weren't symptomatic, but just wanted to know, because there is a substantial percentage of our population that is probably infected and does not know they're infected, what we call asymptomatic or minimally symptomatic. Because of the symptoms that present with this disease, and we know that many people don't progress to a full-blown pneumonia or respiratory failure, they may assume it's just a common cold, or right now we're in allergy season, so they may assume it's just allergies. So we are able to offer testing pretty broadly right now. As long as we have the lab capacity, we have the supplies and the resources to do it. We expect that we may have to go back and forth with it as we see how many people want and need testing, and as we see the outcomes of investigations from our positive cases.
Thank you. I have a follow-up here for folks representing our hospitals. Can you speak to the testing that's taking place at your facilities?
Sure, I'll start. At Lewis Gale, we struggled early on with some of the testing mediums, and so we were able to get multiple vendors to provide the tests. We're very fortunate to have Dr. Bissell and the New River Valley Task Force to be doing the outpatient testing. Although we're not doing general outpatient testing at the hospital, with the 3 vendors we have, we're able to test all of the inpatients and symptomatic patients that we need to test through the emergency room or on the inpatient side.
Thank you, Alan. It's been similar on the Carillion side as well. We have been able to test anybody that really needed a test. At first, the test results were taking a long time to come back, 7 to 10 days, which was a real frustration. But as the tests have become more available and more sites are testing, we're typically getting them back in a day or 2 at the most now. And through our hospital here, we've tested 240 different people for the virus through our emergency department and inpatient areas, and really haven't had the need to test that many more, because I have a strong feeling that we've tested everybody that deserved to be tested.
Okay, thank you. We touched on antibody testing a little bit earlier, briefly. I don't know if anyone of the panelists would like to respond about research efforts that are being considered to screen for antibodies.
Kevin, I wanted to provide a little bit of input from our clinic's experience is not as kind of robust as what you've heard from the hospitals and from Dr. Noel Bissell. We are very limited in the amount of testing that we can do, in part because of the lack of availability of supplies. So in our Christiansburg office, we have just a handful of the swabs that we need. And in spite of the orders that we place, we may order the test, and get 1 or 2 swabs at a time. So we are pretty limited. But to follow up on what Dr. Bissell said, that it is helpful to think of testing in the 2 major categories: the virus testing that answers the question, do I have it? And the antibody testing that answers the question, did I have it? The problem with the antibody tests is they were all approved by the Food and Drug Administration under an emergency use authorization, which requires a lot less testing than they normally would subject a diagnostic procedure, a diagnostic test too. So there was a huge proliferation of antibody tests, many of which were really ineffective. So in addition to limited accuracy of the tests, the next issue is we don't really know if having the antibody confers protection. It's safe to assume it does, we think, because most every other virus does. But as, again, Dr. Bissell pointed out, this is new. No one has seen this particular virus before. So it has yet to be seen whether or not the presence of antibody confers protection against reinfection.
Thank you, Dr. Roberts. Anybody else want to follow up on the antibody item?
Kevin, I will say that the antibody test that the Harm Reduction Coalition is offering through our New River Health District testing sites is what we call a point of care. It's a little finger stick test, and the results come back in approximately 10 minutes. As Dave said, we're still trying to figure out the validity and the reliability. We try to put it together with the clinical picture. The biggest thing is that we're finding the antibody response to this particular virus is significantly delayed from what we would expect with a typical infection, so that it's not going to be, you're going to often get a false negative if you test before 14 to 21 days after symptoms onset or the potential exposure. The other thing is that the antibody response almost has a bimodal where it goes up and comes down and goes back up. So we're learning a lot. So we do have some research partners through our universities as well that we work with. And there's another antibody test, which is a formal blood draw called ELISA. And there are some of those that have hit the market now. There are some university research labs which are developing ELISA tests, which are felt to be a lot more reliable when actually looking for the antibody response. There are multiple antibodies that we're talking about. There's an antibody to what's called the nucleocapsid protein. There's an antibody to that spike protein that makes the virus, if anyone's seen pictures of it online, it's that spiky look. And then the virus is also enclosed in what we call an envelope. And these ELISA tests can look at all of those antibodies. So we're just partnering because we have the benefit of some research universities right here in our backyard to look at how things are evolving and to look at the antibody responses, to compare the point of care antibodies with the lab antibodies. And it's just a great partnership to get our own information and figure out. And part of it too is seeing if those antibodies actually do confer immunity and neutralize the virus.
Well, you mentioned our partnerships with universities, and we're absolutely blessed to have them as partners here. And there's recent partnership on testing. And Dr. Bissell, can you talk about the turnaround time for testing and perhaps talk a little bit about the partnership on testing with the Fralin Research Institute?
So yeah, as I think Bill alluded to, initially testing turnaround time was 7 to 10 days or more through our commercial labs, which was what we mainly had. That has come down substantially, but Virginia Tech was able to, Fralin Research Institute was able to get the authority and the approval to basically convert from a research lab to a clinical lab. And they are able to run the molecular test, and they have a very good molecular test if you look at their results and the data that they provide. And they're able to run it in Roanoke, and they're able to run it in Blacksburg. And they have offered their services for our highest risk testing population that needs the most rapid turnaround. So we can get results within 24 hours on the highest risk. Their capacity, they are just ramping up, so their capacity is a little bit more limited now, but they expect to have increase in capacity over the next several weeks. So what may take 48 hours right now will probably be down to 24 hours. A lot of our other testing, our community testing, where people are not symptomatic or are not super high risk, our commercial labs are down, as Bill said, to a 1 to 2 day turnaround as well. So we're in pretty good shape with our laboratory turnaround. Again, that depends on the lab's capacity and how many tests they get. As more and more places ramp up their testing and they get more and more samples, you're going to see that fluctuate.
Okay. We hear about the Abbott testing system and that it produces results within 15 minutes. Is there anything along those lines available in the Neuro Valley now?
So the Abbott testing system requires a specific machine to run that test, and we don't have that machine. And the hospital representatives can speak because I don't think they have the Abbott system. They have other systems as well. So we don't have that in the New River Valley.
I would say at Lewis Gale Medical Center in Salem, they have a test that comes back in 45 minutes. So that's the shortest one I know of. We can get our tests up there and they can get the test results in about 45 minutes.
And so, Kevin, we've got a similar system up at Roanoke Memorial. It's the same one that Lewis Gale's using. The challenge really is just the cartridges that are available for that. Nationwide, a lot of those are being diverted to the high impact areas, New York, Richmond. So those are of limited supply to be used. They're really more so time critical specific cases.
Okay. Thank you. How can a citizen request a test for COVID-19?
So in the New River Valley, we do all of our community testing through our call center. And I don't have that number memorized right now, but we can get that posted. Everybody who calls the call center will be asked some screening questions. But as I said, right now, we're pretty much opening broadly that anybody who is interested in getting testing, we will go ahead and do the test. I will say that young children, we really do look at those on a case-by-case basis because they tend not to cooperate with the swab and it can be pretty traumatic to them. So we are very careful about that. But if they call our call center, we put the information in and we actually can generate an email, which is essentially their appointment, their ticket to come to the testing site. They come to the testing site, they have that email, they show it, they come in and they go through the driving. As I said, it is the nasopharyngeal swab. So we do request that there only be a maximum of 4 people per car. We do have nurses on both sides of the vehicle, so all 4 occupants can get swabbed. And then if they are folks that we are doing the finger stick testing as well, we have an area where they can pull off and get that done as well.
Very good. Well, for those who need the public health call center number, it's 540-267-8240. And the hours are Monday through Friday, 8 a.m. to 8 p.m., Saturday, 8 a.m. to noon, and Sunday, noon to 4 p.m. And if it's after hours, leave a message. And I understand that you all are very prompt about calling back from those I've heard around the region, utilizing the resource. Next question.
Community Health Center, we're really limited in the amount of testing that we can do. So we are limiting to either folks who are symptomatic or have had exposure to a known COVID positive patient. But as a measure of consolation for people that don't have testing readily available, in the absence of a specific treatment for COVID, it's certainly a value for epidemiology to know, how the disease is spread through the community. But as it boils down, we treat mostly based on symptoms. And so the presence of a positive test, if you're sick, you have to go get care. If you're well, stay home.
Good advice. Thank you. Next question came in is, as we move toward recovery phase and reopening, will there be enough testing for patients for elective surgeries, employees and employers? What is our testing capacity?
Kevin, we're going to make sure as we begin to do non-emergent operations and procedures at the hospital that every patient is tested so we'll know their COVID status. It's important to make sure that we're using the proper personal protective equipment, the PPE that we've heard all about these last weeks, and make sure that we don't waste any of this PPE and know the status. And is part of our reopening strategy. We're going to have to test. And we, at this point, have an abundant number of tests and feel comfortable being able to do that. Dr. Charlie Bissell, what do you add to that?
One of the other reasons for testing in advance is so that we can identify patients that are COVID positive and stratify that to see if they really need to, their risk for surgery. What we've talked about with, Noel said, is that the respiratory issues as well as the hypercoagulable state. And so the folks that are, the patients that are COVID positive tend to have more complications. And so that's, another reason why we would put their surgery off if it was in their best interest. The other reason for testing is so that we also protect other patients in the hospital as well as our staff.
Yeah, at Lewis Gale, I would agree. I mentioned earlier we have 3 different vendors, and Dr. Bissell mentioned some of them. The supplies are in short status right now, and so we don't use those for certain types of patients. We have started doing non-emergent procedures at the hospital. We started this week, and 100% of the patients are being tested 24 to 48 hours in advance. So we have the day before, we have the results. And so we ask the patients after they begin the testing process to isolate prior to, and if there is a positive COVID patient, which we haven't had yet, but when that does occur one day, that will be the physician's conversation about how do we make sure that the patient's safe and put off the surgery if it's not urgent, emergent, to get the patient into the safest position to have the procedure. But that's one of the reasons why we have 3 different vendors, and we can get next day results, 2 to 3 day results, and then that short test. We use them for different types of patients.
Okay. Is there a way to find out the daily number of tests that are being conducted within the Neuro Valley?
So the VDH website, I know, had the number of tests being conducted, and I think they're doing some revisions to it to try and provide more data. Kind of piggybacking on what Dave said, the actual number of tests, I don't think is as critical of an issue as the fact that we're able to respond and we're able to offer the testing for us to look at disease prevalence, for us to take care of patients who are symptomatic and sick, and for us to do our contact tracing for our mitigation efforts. And our testing in the New River Health District is going to vary widely day by day. We are doing, like I said, today we did 137 out in Giles. Tomorrow we have some follow-up testing in some facilities that we need to go do. We have another testing site at Blacksburg High School on Friday, but it's shorter, so probably won't do 100. So it's going to go up and down, but again, the actual number is not so important as the fact that we're getting the community testing, we're looking at our disease prevalence, we're doing the contact tracing, and we're getting testing for our sick individuals. But that is going to be on the Virginia Department of Health website again as they add those different statistics.
Very good. I'm not sure if the panel can speak to this, but there's been news stories about Virginia ranking pretty low among the 50 states about access to testing. Do you foresee that to increase in Virginia here soon?
I think testing is definitely increasing in Virginia. I can't speak for some of the other areas. We're fortunate in Southwest Virginia that we were not one of the big hot spots to hit the area, like our northern sections, Richmond, are more urban areas. So for them, they got caught kind of fighting the pandemic as it arrived on their doorstep while they were trying to secure testing. We had a little bit of advance notice and we were able to kind of put some of a framework into place. I honestly don't know where we are as far as per capita testing and whatnot compared to other states. Everyone knows there were some glitches early on. I do know the state now has a task force that is actively engaged in securing the supplies for testing. and then also securing the laboratory capacity. So we have the commercial labs, we have the Quest and the LabCorp. Lewis Gale actually is also contracting with another commercial lab out of, I think it's Tennessee. And then we have our research labs. So Fraylin's come up and running. University of Virginia, Virginia Commonwealth, they were able to get some laboratory capacity up and running. And we have our state lab, the DCLS lab. And in the beginning, it was only doing the CDC administered tests, and those supplies were very limited, but then they came up with their own test, and they've increased their capacity as well. So where we rank and whatnot, I can't speak to that, but I do know that our capacity is markedly increasing, and it's not just the testing itself, the supplies to do the testing, and we've had some creative solutions to finding those things.
Great. Well, change topic here from testing towards mental health. The sense of isolation related to working from home, the closure of so many venues that we rely on for personal interaction, and the social distancing is really taking a toll on mental health. Are there options and services available to those in the community that need help?
Kevin, I'm glad you bring this issue up, because I think that's one thing that people often kind of don't think about. When you have a crisis such as this hit, your response is to that immediate need. And like I said in the opening remarks, we have folks out there that struggle with mental illness, substance use issues, as well as developmental disabilities. And they still have those issues that need to be cared for, and they need services for. In this time of a crisis, like you said, it's disrupted our professional lives, our day-to-day routines, our family lives. We have families who are struggling with trying to figure out how to work, how to pay their bills, how to provide childcare, and do homeschooling all at the same time. And so that is a tremendous amount of stress. I know that a lot of providers of behavioral health services have moved to telehealth services, so we can provide services to those who need it by connecting them through formats like we're doing now through, I guess, a web-based platform, or we can do it through the phone lines. And in some cases, we still have clients coming into our clinics for services. So services are still available. And I would encourage people to reach out to a provider and just ask them what kind of options are available. I know that New River Valley Community Services has really tried to pour a lot of energy in getting the messages out through social media that we're still here and we're still open, whether that's providing services through telehealth or doing things in person. We will kind of assess that and make sure that we're taking appropriate steps to ensure everybody's safety and well-being. So some things that we're doing online or through WebEx or telehealth have changed how we do business, but we're still here and we still want to make sure people's needs are taken care of, because it's a very stressful time.
And Kevin, we have St. Albans here on our campus. It's a 36-bed psychiatric facility that cares for the community. And we had to reduce our bed capacity because we didn't want to cohort patients with unknown COVID status together and spread infection. So we had to reduce the number of patients that we could admit to our psychiatric facility at a time, as James says, it's needed so desperately. But we've pivoted a bit. We're doing a significant number of telemedicine visits. As I said earlier, we, across the clinical enterprise, have done almost 80,000 telemedicine visits. A lot of them have been for our psychiatric patients, and it's worked out fairly well. Our no-show rate is practically zero for that type of visit. And we've deployed one of our psychiatrists in particular, Dr. Xavier Prude-Holmes, from the inpatient area to the emergency department. We had a person who was struggling on Friday afternoon. Dr. Prude-Holmes got advance notice that he was coming into our emergency department, met him at the front door, treated him in the emergency department in a private area. So we've flexed, we've pivoted it a little bit, and providing more outpatient care through the emergency department, admitting patients as necessary to the psychiatric facility, but really capped our beds to make sure that the patients are safe through that entire process.
Thank you,
I
Bill.
mean, we at the Community Health Center had a similar experience with telehealth. All of our behavioral health people are doing exclusively telehealth visits now. We have the capacity. Some patients with particular mental health issues don't deal well with the camera. There can be suspicion issues, and who else is listening to us, and those patients tend to do better face-to-face. So we still have the face-to-face capacity. But as Bill noted, our no-show rate for behavioral health has actually decreased since we're doing telehealth, because people can do it from their home. But this whole mental health issue that we're discussing is a predictable wave that follows disaster. The Kaiser Family Foundation did a survey. They said that 45% of respondents said that their mental health had deteriorated, and 19% of people said that it had deteriorated to a serious degree. Depression, anxiety, substance use, domestic violence, all of those things are much, much higher following events like this, even suicidality. So we've just started, we do some substance use disorder treatment, and have started an online group that we're going to be launching. And we basically give advice just like we would to anybody else with mental health issues. You start with the things that you can control. You try to sleep well. You be careful of your diet, exercise, and there are online resources. There's a website called Headspace, which is primarily a mindfulness-based approach to mental health. But there are a number of other sites. There are AA and NA meetings available virtually. So there really is there's a patchwork, and I can get you websites if there's some place we can send that to you for community, as a community resource. We can collect those things for you.
Kevin, I would just want to add that if there's an individual out there or someone who's concerned about a loved one or a family member or friend who's struggling, I think it's the mission of the task force to make sure that we connect folks with resources before symptoms escalate and reach a higher level. We want to avoid those kind of crisis situations.
Absolutely. And any resources that the panel sends along, we'll post those to the town hall website that I referenced earlier. I'm glad to hear that you all are making telemedicine services available and you're seeing the participation increase significantly. Such a valuable service. James, with Neuro Valley Community Services, there's people that are quarantined at home right now. And do you all provide services for folks who are at home in quarantine?
We are still providing services, like I mentioned earlier, to protect our clients as well as our staff. We will usually contact them before we make a home visit and do an initial screening just to see if they have any symptoms or they've had any concerns or been in contact with people that may have been exposed. And if they haven't, then we are allowing staff to go out and provide services to them in their home. If they are in a situation where they may be contagious, then we are going back to telehealth services. In extreme situations, if someone's having a psychiatric emergency, we've been working with the task force to make sure that we can provide services to those folks to make every effort to get them the resources they need to prevent them from going into like a psychiatric hospitalization. So we have, like someone mentioned earlier, we have the PPE, the protective equipment that we can use for staff. And in certain cases, we might ask clients to use that as well if we're working with them personally.
Great, thank you. At this time, we aren't able to get routine medical care and screenings. Now, how much longer will that go on? as this person submitted a comment, they're concerned that there'll be an increase in diseases that are discovered too late for effective treatment, especially if routine cancer screenings are delayed much longer.
That's a great point. I appreciated seeing that question in advance. And frankly, I've been worried that people are putting off care. Some of the cancer screenings and what have you, they can wait a little while. But I worry about patients that have had chest pain and decided that their chest didn't hurt so much they should risk themselves going to the emergency department and becoming potentially infected. People have stayed away. I told you how dramatically our volumes have dropped. So I know that with our reopening plans, we'll be at about 50% normal capacity in a week and a half. That's phase 1. Phase 2 will have us at about 75% of our normal capacity for these types of tests and screenings. And then hopefully shortly thereafter, we'll be at near or nearly normal levels of screening for people. But as Dr. Charlie Bissell said earlier, we have a scoring system for figuring out which patients are most urgently needing the services that we provide. But I hope that we'll get back to a normal level of screening and care for the routine things in fairly short order.
And Bill, I can add that, as we're doing that from the surgical side, in parallel, the primary care are ramping up their visits. They have taken a great advantage of the telemedicine, about 75% of the visits right now. They hope to get that up to 90. And then as we get more screening, testing, and the PPE settled, they'll be seeing more folks that way. Radiology also is working in parallel. So, we did the mitigation, we kind of tamped things down to kind of, flatten the curve. And then now, all of these things are starting to ramp back up together. So it won't be, it won't be immediate, but it's coming along.
Kevin, we have a similar outpatient experience. We really do the screening on a case-by-case basis. I'm a gynecologist by training, and Pap smear intervals, as long as the Pap is done in conjunction with human papillomavirus testing, that's a 5-year interval for someone who's had a series of normal tests. So to ask that woman who's had, regular testing to wait another 3 months, that's not, too much to ask. On the other hand, someone who's had a history of abnormal Pap smears, you weigh the risk of her coming into the clinic and being exposed to somebody or leaving her home against the risk of her having an undetected change in the cells on her cervix. So these really are made on a patient-by-patient basis. Same is true with management of chronic medical diseases. So for example, someone on blood pressure medication who's been stable on a particular dose for a very long time, we have just routinely extended and given them 90-day prescription. On the other hand, someone who has struggled with diabetes control, those folks may actually still be coming into the clinic. But it really is pretty remarkable what you can accomplish through a telemedicine visit.
Yeah, and I think the important piece here to mention is that people who need the care need to seek the care. We are seeing people who are delaying care from concerns coming into the emergency room of the hospital and then being more catastrophic when they end up receiving the care. At the hospital, we are open for all of the different types of screenings, but we're working closely with our physicians to get the most important ones in. And so as we go through, we're open for surgery, but we're working with the physicians to have the conversation, what's important right now. And as we ramp back up, we're going to make sure that the people who need the care get it first. The urgent folks in the screening and the care get it next. And the truly elective folks, as we come on board, we're going to be prepared to provide them care as well.
I think another message that needs to come out is that we've done a good job, both hospitals, all 4 hospitals in the area, in terms of protecting, patients. And so, patients should not be afraid to come to the hospital if they have a need. If they're having chest pain, stroke symptoms, abdominal pain, be it whatever it is, we can provide care safely. All right. We have screening at the front door for folks coming in, and we can isolate folks that are, potential COVID persons under investigation. They go down one pathway, and we can separate that from the other folks that are not at risk, and then protect them. We've got, the universal masking. We've got a limited to no visitor policy, based on exceptions. The social distancing. So all of those things are in place so that folks should feel safe to come to either one of the hospitals for their needed care. If it's something that is, like Dave was saying earlier, that if you're not sick, you don't need to go to a place where you put yourself at risk. But if you are having some symptoms, by all means, we're safe. You can come and see us.
Thank you.
Billy, what are you seeing in the hospital?
Well, I'd just like to comment based on what Alan and Dr. Bissell and others have said. We're definitely seeing those patients that are waiting sometimes too long to come to the hospitals, those patients with chronic diseases such as COPD or CHF. And we do have a safe environment in the hospital. I think it's important for people in the community to know that that we're considering what we call PUIs, or patients under investigation. We have casted a wide net to rule out patients for suspected coronavirus or COVID-19. So we've been doing this for several weeks now. We've expanded our search. And so those patients who do have chest pain with acute coronary syndrome or COPD, or just a bacterial pneumonia, many other conditions, we can safely treat them and they'll get appropriate treatment, and they should not worry about coming into the hospital and being exposed to COVID-19. I will like to note too that in the Lewis Gale Regional Health System, now for a couple of weeks, when we do have a patient who has confirmed coronavirus at Lewis Gale Hospital Montgomery, and Pulaski, and Lewis Gale Hospital Allegheny, those patients are being transferred to Lewis Gale Medical Center, who they provide all the services that are needed to treat the patient. So we have treated a few in the hospital, but we've been doing this now for the last couple of weeks as well, just to ensure further safety. So we're expanding a big net, capturing, ruling out those patients who are negative, and if they are confirmed, then we're sending them to our sister facility at Lewis Gale Medical Center in Salem.
Just to piggyback real quickly too, Kevin, on what Billy just said, I think it's important to note that while COVID is getting all the media attention and everybody, it's on their minds, in the New River Health District, only 4.5% of the tests that we're doing are coming back positive for COVID. And that's including people who are symptomatic. So, there are other pneumonia causes out there. They're not all COVID. And people have to understand that. And certainly in other areas where the prevalence of disease, the hotspots where the disease is much more prevalent, and they're focusing their testing on the highest risk, their percentage of tests coming back positive are going to be higher. But we're getting a pretty broad community testing program here. And I think we have a realistic number that, 96% of the time, 95% of the time, your symptoms are going to be caused by something else.
It sounds like the message is really that we're all still providing services. It may look a little different. So the best bet is for folks to call when they have concerns.
Thank you, James. You nailed it. I have just a couple minutes left for our panel, and there's two topics I want to try to touch on before we wrap up. The first is about masks. And is it accurate that the benefit for a person wearing a cloth mask is primarily to protect others and secondarily to protect oneself? Also, how can the public be educated to wear a mask out of altruism, a visible sign for caring for others?
So, yeah, masking is mainly to protect other people. We had gotten away from a lot of our public health responsibility to our community as far as covering coughs and sneezes and doing a good job with hand washing. So that mask helps protect if someone does cough or sneeze, that those air droplets are not being spread all over the place. I mean, it does provide a barrier. So it of course can provide some protection, but by and large, the greatest protection of that kind of a mask is to protect other people.
You know, and other cultures do this. You know, it may be one of the reasons why the Asian cultures were able to handle this better than, you know, others have. When someone's ill, say in Japan, they wear a mask to protect others. And hopefully, just for social responsibility here in in the United States, we can get to that, and that it's not looked upon or frowned upon or mocked, and it is, you're just doing me a favor by putting that mask on so that you're protecting me. It's the same thing with hand washing and coughing and into the elbow, and just it's courtesy.
Thank you. And Dr. Bissell, perhaps you can address this last item for us. And it's about the Mountain Valley Pipeline construction that's scheduled to resume. And there's been a couple of questions that were submitted about whether that's advisable for the community and allowing a lot of out-of-state workers to come in when we're advised to stay at home at this point in time.
So I think the first thing to note is that a lot of pipeline workers have remained in the community, so they're still here. We have other construction projects in the community where there are subcontractors coming in. The other thing is our state borders are not closed, and we have people coming back and forth all the time. People who bring us our vital supplies, those trucks that are delivering to Kroger and our food stores, to Home Depot, to Lowe's, those folks are coming back and forth across state lines all the time, and we really can't restrict it. As far as the pipeline goes, it is in the energy sector, and that is considered an essential service. It is a critical infrastructure service. So we have to be mindful of that. We ask of those folks, just like we ask of anybody else who is traveling, that they respect the public health guidance. And if possible, we would love to have them self-quarantine for 14 days or as long as they possibly can. We would love to have them follow the same recommendations that we're telling everybody else, to limit those public interactions. If they're out and about in public, to wear a mask, or to not be out and about in public if they are sick. And fortunately, a lot of the work takes place outside where the risk of transmission is much, much lower. There is guidance on the VDH website for these sectors, and our environmental folks do provide a lot of guidance as far as those workers.
Thank you, Dr. Bissell. Well, we're rapidly approaching the end of our 1-hour program. I think everyone will agree the community has submitted some very thoughtful questions, which has spurred some informative discussion among our panelists this evening. And as we look forward, the task force is creating the playbook to help everyone in the Neuro Valley navigate the next phase, recovery. The series of our virtual town halls is your opportunity to continue that conversation. We invite you to join us each Wednesday at 6 p.m. If you're not able to watch live, the series will be archived on YouTube. Links will also be posted to agency websites and social media. The series will also be rebroadcast on local access cable stations, including Comcast and Shentel Channel 190 for Christiansburg and Montgomery County, along with Comcast Channel 2 in Blacksburg. Additional dates and topics include the following: May 13th, Law Enforcement, Fire and Rescue; May 20th, Local Government; May 27th, Local and Small Businesses; June 3rd, Education focusing on K through 12; June 10th, Education focusing on colleges and universities. And before we wrap up this evening, I'd like to extend a special thank you to not only our panelists, but also those behind the scenes who are making the virtual town hall series possible. And they're the public information officers who serve local governments, agencies, and higher education institutions in the region. The program would not be possible without their contributions. So thank you all very much for joining this evening, and be well.
Thanks, Kevin.
Thank you,
Thanks,
Kevin.
Thanks a lot, Kevin.
Thank you.